Here is the classical ward mistake we often commit. A patient has an A1C of 10 to 11%, we immediately start them on insulin. But the real question is not the glucose number. The real question, does the patient have insulin resistance or is it just insulin deficiency? Because only one of these truly mandates insulin therapy. Type 2 diabetes is not a single disease. It exists on a spectrum between severe insulin resistance on one side to progressive beta cell failure and low insulin on the other side. In insulin resistance, peripheral tissue, especially muscle and liver, have impaired insulin signaling pathways. The insulin levels are high, sometimes massively elevated. But in the other end of the spectrum, there is insulin deficiency due to beta cell exhaustion and destruction. So there is very low levels of endogenous insulin. Hepatic gluconeogenesis become unchecked and ketosis risk increases. Clinically, these two states behave entirely differently and require different therapies. Data from UKPDS and later analysis have shown that beta cell function decreased progressively, losing roughly 4 to 5% every year after the diagnosis in type 2 diabetics. So 10 years down the lane, they will have 50% less of beta cell mass than when they had the diagnosis was made. But here is a clinical nuance. Large trials like LEADER, EMBARK, SUSTAIN demonstrate that patients with preserved insulin production often respond dramatically to GLP-1 receptor agonists and SGLT2 inhibitors, meaning insulin may be totally avoided in these patients. Now, in real world practice, patients who present with rapid weight loss, low BMI, ketosis or marked hyperglycemia, they often have LADA and they need insulin. They may initially look like type 2 diabetics but progress rapidly to insulin dependence. So if glucose control deteriorates quickly despite oral therapy, check GAD and C-peptide once again. And these can give you clue. At the bedside, 3 clues that strongly suggest insulin deficiency is unintentional weight loss, ketosis or ketonuria, low or inappropriately normal C-peptide during a hyperglycemia. This will be the most palpable change. So if C-peptide is low, when the glucose is high, the pancreas is failing and the insulin is not optional, it is mandatory. Treat the physiology, not just the glucose level. Insulin resistance needs strategy, but insulin deficiency needs insulin.